Good morning, Dr. Asukile. My name is Rogers Jere. I am a fifth-year medical student from the University of Zambia. Today I have a 65-year-old male patient who presented to the hospital after being found unresponsive. His family mentioned that he had suddenly lost the ability to speak and move his right side just before collapsing. He has a history of hypertension, diabetes, and hypolipidemia, but no prior strokes or TIAs. He was previously compliant with his medication until 2 months ago when he stopped taking them due to financial difficulties. Upon further questioning, he reported no preceding headaches or visual disturbances. However, he has been smoking for the past 30 years and consumes alcohol regularly. His father also suffered a stroke in his late 60s. The patient lives in a rural area with poor access to healthcare. Summary of history findings: male, 65 years old, sudden onset of speech difficulty in right-sided weakness, history of hypertension, diabetes, hypolipidemia, poor medication adherence due to socioeconomic factors, long-term smoking and alcohol consumption, family history of stroke, impression. This patient likely suffered an ischemic stroke, considering his risk factors and the sudden onset of symptoms. Differentials: ischemic stroke, most likely. Hemorrhagic stroke, space-occupying lesion, less likely given the acute onset. Hypoglycemia, though unlikely based on his presentation.
Rogers, impressive attempt at history taking, impressive for someone who forgot to check basic vitals. Did you at least confirm the glucose levels to rule out a simple case of hypoglycemia, or were you too busy playing detective? Now, let's test your knowledge. Define stroke, if you can manage that without tripping up.
Stroke is an abrupt onset of a neurological deficit that lasts more than 24 hours with no apparent cause other than vascular origin.
Not bad. Almost like you read it from a book this morning. Now, what are the types and risk factors of stroke?
There are two main types, ischemic and hemorrhagic. Ischemic strokes account for about 85% of cases, while hemorrhagic strokes make up 15%. Risk factors include both modifiable factors, such as hypertension, diabetes, hypolipidemia, smoking, and alcohol consumption, and non-modifiable factors like age, gender, and family history.
You actually remembered the percentages. Wonders never cease. And what about the pathophysiology of stroke?
In ischemic stroke, there is an obstruction in the blood supply to a part of the brain, usually due to a thrombus or embolus, leading to tissue ischemia and infarction. Hemorrhagic strokes occur due to the rupture of blood vessels, causing bleeding into the brain tissue or the surrounding spaces.
Could have been worse. Now, what are the classic signs and symptoms of stroke?
Sudden onset of neurological deficits, such as unilateral weakness or numbness, difficulty speaking, visual disturbances, and balance issues. Hemorrhagic strokes may also present with headaches, seizures, or vomiting.
Very comprehensive, probably too comprehensive for a real-world scenario, but we'll allow it. And the poor prognostic factors.
These include a low Glasgow Coma Scale score, pontine hemorrhage, severe hemiparesis, hyperglycemia, hypotension, and poor oxygen saturation.
I see you've at least glanced at the textbook. Primary and secondary prevention.
Primary prevention involves managing modifiable risk factors like hypertension, diabetes, hypolipidemia, smoking cessation, and exercise. Secondary prevention includes antiplatelet therapy, blood pressure control, and cholesterol management.
Did you just Google that? Anyway, let's move on. Present your examination findings. And this time, don't miss anything obvious, like, I don't know, vital signs.
Yes, Dr. Asukile. On examination, the patient is conscious but aphasic. He has right-sided hemiplegia with hyperreflexia and an upgoing plantar response. His blood pressure was 190/110ths of a millimeter of mercury, and his pulse was irregular, suggestive of atrial fibrillation. Cardiovascular examination revealed a displaced apex beat, and there was no evidence of murmurs. Respiratory and abdominal examinations were unremarkable. No signs of trauma or injuries were noted. Right-sided hemiplegia, aphasia, hypertension, 190/110ths of a millimeter of mercury. Irregular pulse, likely atrial fibrillation, impression. The findings suggest an acute ischemic stroke, likely cardioembolic due to atrial fibrillation. Differentials: ischemic stroke, likely cardioembolic. Hemorrhagic stroke, space-occupying lesion.
Good. You managed to remember to check the blood pressure this time. A stroke with atrial fibrillation, who could have guessed? Now, remind me what you know about the pathophysiology of a cardioembolic stroke.
In a cardioembolic stroke, an embolus, often from the left atrium in a patient with atrial fibrillation, travels to the brain and blocks a cerebral artery, most commonly the middle cerebral artery.
Not bad, Rogers. At least your brain hasn't suffered an embolic event yet. Now, tell me, what investigations would you order and why?
I would start with a CT scan of the brain to differentiate between ischemic and hemorrhagic stroke. If it's ischemic, I'd perform an ECG to confirm atrial fibrillation, followed by an echocardiogram to identify any cardiac sources of emboli. Blood tests, including glucose, cholesterol, and clotting profiles, are essential to assess risk factors. I would also request a Doppler ultrasound of the carotid arteries to check for atherosclerosis.
Good, at least you didn't order a lumbar puncture for this poor man. And what about MRI?
An MRI can help identify ischemic lesions early and provide better detail on the extent of brain damage.
I thought you'd forgotten about that. Now, tell me about your management plan.
For ischemic stroke, if the patient presents within 3 hours of symptom onset, thrombolysis with TPA is indicated. After that window, antiplatelet therapy with aspirin should be initiated. For long-term management, I would recommend anticoagulation with warfarin if atrial fibrillation is confirmed. Control of hypertension, glucose, and cholesterol is also essential. Rehabilitation with physiotherapy and speech therapy will be needed for recovery.
Well, you've redeemed yourself slightly with that answer. At least you didn't try to thrombolize a hemorrhagic stroke patient. Tell me, what's the danger of lowering blood pressure too aggressively in this case?
Lowering the blood pressure too much could reduce cerebral perfusion and worsen the ischemic injury.
Excellent. You've managed to survive this round, Rogers.